may not have the myoepithelial cell layer, and these lesions can occur anywhere in the ductal system of the breast. What you have to remember is that papillary morphogenesis is not a feature of normal breast tissue. That means when you start to see anything which looks papillary in the breast tissue, that means you are dealing with something which is a pathological process. So coming to the classification of papillary lesions, the latest WHO classification is actually 2019, and whatever the lesions were enumerated in WHO 2012 are same in 2019, but the old classification 2003, there are some changes which were made during 2012, and the changes are like we used to say the intraductal papilloma of two types, central and peripheral. Now you don't have to say whether it is a central and peripheral intraductal papilloma. You just say it is an intraductal papilloma. There was term which was in old classification which to say a typical intraductal papilloma. Now we just don't call it a typical intraductal papilloma, but we say that it is a papilloma which is showing either a typical ductal hyperplasia or ductal carcinoma in situ. Papillary DCIS, which is also called intraductal papillary carcinoma, remains the same in the new WHO. Encapsulated papillary carcinoma remains the same, which is encapsulated papillary carcinoma. But what was a new entity which was added in WHO 2012 was solid papillary carcinoma. Invasive papillary carcinoma remains the same, and so we'll move. So papillary lesions by number and location can be solitary and multiple. So solitary lesions, which are usually they occur in the central location of the breast, that means they usually occur at the retroalar region. But solitary lesions can also occur in the periphery of the breast, which arise from the terminal duct lobular units. And most often, the multiple lesions, multiple papillary lesions, occur in the periphery of the breast. Because of their locations, you can have a different clinical presentation for centrally located lesions and peripherally located lesions. Most often, the centrally located lesions, which are there in the large lactiferous ducts just below the nipple, they present with nipple discharge, and in this case, when there is a papillary lesion, you have nipple discharge, which can be bloody nipple discharge, or sometimes it can be pink nipple discharge. Whereas the lesions which are there in periphery, they can present as a palpable mass. Also, the retroalar lesions also can present as a palpable mass, and both these locations have lesions which on radiography you will see as opacities as well as microcalcifications. So, of three things. First is cytological features. Second is architectural pattern, and third is whether there is presence of an internal or external myoepithelial cell layer. When we say cytological features, that means we are trying to see if the cell population which is there in the lesion, whether it is a heterogeneous cell population or whether it is a homogeneous cell population. And what is a nuclear grade? Whether nuclear grade is low, intermediate, or whether it is a high nuclear grade. And then you come to the architectural pattern. In architectural pattern, you mostly see whether it is a nodular lesion, what the papillae which are there within the lesions, which are usually broad papillae, or whether they're going to be slender or thin papillae. That's how we see these three things to make the classification of papillary lesions. Now, this is a table which is quite a busy table here, which shows you a difference between different entities of the papillary lesions, right from benign end, which is intraductal papilloma, till the more malignant lesions like invasive papillary and the solid papillary carcinomas, which can be differentiated based on architecture, epithelial component. So what you have to just remember in the architecture, that the lesions which are towards the benign spectrum, which is like intraductal papilloma, and the papilloma which has got a focal area of atypical ductal hyperplasia or DCIS, will have the papillae which are very broad or blunt papillae. When you move towards the more the pre-malignant or malignant lesions of the papillary lesions, you start to see that these papillae start to become slender and thin, and they can start showing you a complex branching as well. In solid papillary carcinoma, you don't see a proper broad or slender papillae, but the papillae what we see are actually a very delicate fibrovascular septa which are seen, which are like what you have to say that these are kind of papillae there, which are inconspicuous. In epithelial component, towards the benign spectrum of the lesion, you have more heterogeneous cell population. You can have usual ductal hyperplasia or apocrine metaplasia in these lesions, which is like intraductal papilloma. And when you move towards the more of a malignant lesions, you start to see that the cell population starts to become more homogeneous, and the architecture and the cytology is that of DCIS uh, or it has nuclear grade, which is low or intermediate nuclear grade. And interestingly, if you see the adjacent ducts which are there adjacent to the papillary lesion, in intraductal papilloma, the adjacent ducts may show you usual ductal hyperplasia, but in other lesions, you start to see sometimes you can have DCIS. So there is a very important role of myoepithelial cells in the diagnosis of papillary lesions. You have to check where the myoepithelial cells are present, where you have to look for two locations actually, whether the myoepithelial cells are present within the papillae or whether these myoepithelial cells are present in the periphery of the in the lesion of the periphery of the lesion. So if you take intraductal papilloma, which is a benign lesion, you will have myoepithelial cells within the papillae as well as myoepithelial cells in the periphery of the duct also, which is involved by this lesion. When you move towards papilloma, which has got ADH and DCIS, you will have presence of myoepithelial cells in the area where there are typical benign papillary projections are there, but these myoepithelial cells will be absent or reduced in area where you start to see atypical cytological morphology. Myoepithelial cells will be present in the periphery of the ducts which are involved by this lesion. In papillary DCIS, you will have absent myoepithelial cells within the papillae, but those will be present in the periphery of the ducts. In encapsulated papillary carcinoma, you will have absent myoepithelial cells within the papillae as well as in the periphery of the lesion, and most often, more than 85% of the cases will show absence of myoepithelial cells in the periphery of the duct, nodules or the ducts involved. In the solid papillary carcinoma, you have absent myoepithelial cells within those inconspicuous fibrovascular core, and they will also be absent around the nodules of the solid papillary carcinoma. In most often, in more than 70% of the cases, but few of the cases you may see discontinuous or myoepithelial cells in some of the nodules. In invasive papillary carcinoma, you will have absent myoepithelial cells not only in the papillae as well as it will be also absent in the periphery of the lesion. So this picture, this can tell you the more about where the myoepithelial cells should be seen. Now, if you see these green dots are actually myoepithelial cells in papilloma. What you are seeing here is that these myoepithelial cells are there in the papillae also and also in the periphery of the duct. So it is present in both the locations in the benign lesions. When you have papilloma which shows you ADH or DCIS, you have myoepithelial cells which are present within the papillae which look benign papillae, and myoepithelial cells will also be there in the periphery of the duct. But the area which shows you atypia, that means atypical cytological features which resemble ADH or DCIS, you will have either absent myoepithelial cells or they will be reduced in the number. You come to papillary DCIS and what you see is that here there will be no myoepithelial cells in the papillae, but they will be present in the periphery of the duct. When you come to encapsulated papillary carcinoma, myoepithelial cell layer is absent within the papillae as well as is it absent around the lesion as well. So ISC has got very important role in papillary lesions when you are not very sure on your morphology, whether the lesion which are dealing with, whether it's benign, pre-malignant or malignant lesion, then you may have to resort to ISC and you have to use it for two settings. One is to show whether there is presence or absence of myoepithelial cell layer. For that, we use myoepithelial markers like P63, smooth muscle actin, CD10, calponin, and smooth muscle myosin heavy chain. You also can use markers like estrogen receptor and basal cytokeratins. So basal cytokeratins, usually what we use is CK56 or CK14 or cocktail of high molecular weight cytokeratin that you use to show that whether this epithelial proliferation is clonal or whether it is a polyclonal. Like polyclonal population will be there in usual ductal hyperplasia versus you will have a clonal population of ductal cells in ADH or DCIS. So there are these different markers I already enumerated to show whether there are myoepithelial cells or not in the papillary lesions. So what most commonly used is a P63. It is a nuclear marker. It has got a high sensitivity around 99 to 100% of the times, and it has got very low stromal cross reactivity. So it has got very good specificity as well. You can also use markers like calpain and SMA, which gives a cytoplasmic staining. They have fairly good sensitivity, but they lack the specificity. In what sense they lack the specificity is that they can cross react with the myofibroblast around the ducts or within the papillae, and so that the interpretation becomes quite difficult. So that's the way they can lack the specificity. So what we use in our lab, or rather I use in my lab, is that I usually use P63 as the marker because it is a nuclear and it gives you nice crisp positivity. Now, how do we use estrogen receptor and basal cytokeratins for papillary lesions? As I said earlier, UDS, that is usual ductal hyperplasia, is a polygonal population. So it will show you mosaic pattern of staining for estrogen receptor as well as basal cytokeratin, which is CK56 or CK14. Whereas ADH and DCIS is a monoclonal proliferation. So in such a proliferation, you usually see uniform staining for ER, provided that this proliferation is actually of a low or intermediate nuclear grade. Then you will see uniform strong staining for ER. And if you look at the CK56, you will see that in these areas of ADH or DCIS, there will be no staining for basal cytokeratins. What one has to remember, one caveat, that apocrine proliferation, which are usually associated benign papillary lesions like papilloma, can be ER negative and CK56 negative. So don't interpret that ER and CK56 in such areas. So this is the first quiz question I'm putting forth. What you have to do is actually you have to scan this code from your mobile. Once you scan this code, you will be prompted to a page wherein you will see the quiz and you will see the options. Once you see the options, you can choose one of the correct, whatever options you feel is the correct options, and then you just just send it, and then at the end of the quiz, we will see which option is the correct option. So I will let people join, and then I will start the quiz. Once you are joined for this first question, you don't need to rejoin again for the next question. Your screen will prompt you once the next question will come on the screen. Okay, I see good number of people have joined. Okay, great. Now I'll put the quiz. So all of the following immunostains mark myoepithelial cells except first option is smooth muscle actin, second option is CK56, third option is P63, fourth option is CD10, and fifth option is none of the above. So you have 10 more seconds to answer. So excellent. So some people have chosen, 8% of the people have chosen SMA as the answer, 25% have chosen CK56, some have very few of them have chosen P63, some of them have chosen CD10, and none of the above is 29%. So you have actually a hung house. And what is the answer? Answer is actually none of the above. So if you see, myoepithelial cells can be marked by, as I already told you, by SMAs, P63 and CD10. But CK56, even though we used to show something whether which is clonal or polyclonal, it can also mark the basal cells, so or myoepithelial cells. So CK56 can be used marker for even to show whether there are myoepithelial cells present or absent. Now coming to the first lesion, which is benign lesion intraductal papilloma, and how do we define it? It is a proliferation of epithelial and myoepithelial cells over a fibrovascular stalk, thus creating a arborescent or tree-like structure within the lumen of duct. Now, if you see this image, you can see that this is a large duct which is dilated duct which has got within this very broad branch-like fibrovascular course, and on which there is some epithelial proliferation which is happening. What even on the low power one can make out that this lesion looks blue and pink. The moment the lesion looks papillary and also looks blue and pink and is good pink there, one start to think or one has to suspect that this probably will turn out to be a benign papillary lesion. And then you start to move on to high power. Now here again you see these are the thick branches. If you see it is like a tree-like lesion, then you one will say this is thick branches, and then there are small branches which are giving rise from the thick branch. That means it is like this thick fibrovascular course giving rise to small fibrovascular course, and on which you see this proliferation of the cells, which are of the two types actually. One is a luminal cell or a ductal cells, and then abluminal cell, which is a myoepithelial cell, which is towards the stroma of the core. And you can make out that at places one can see that those cells can look little clearer, myoepithelial cells. Sometimes they can look spindly, and that's how you start to see whether there are two cell population. One is luminal cells, and what is abluminal, which is a myoepithelial cells. Once you see it on HNE, you don't actually need to go and do the IHC. But if you are in a doubt, then you use markers, which I already mentioned. So I have used in this case just to demonstrate you how one can use the IHC markers. This marker is a P63. One can see that the fibrovascular core, they also have positive cells, which are myoepithelial cell nuclei. That means this course, fibrovascular cores have these myoepithelial cells, as well as myoepithelial cells are also present in the periphery of the duct. Similarly, even SMA is showing the same cells, that the myoepithelial cells are marked within the course as well as they have been marked in the periphery of the duct as well. So if you look at the high power of this course, you can make out this course look quite broader, and then you start to see the cell cytology much better. You have towards the luminal side, which are luminal cells, and towards the abluminal side, these myoepithelial cells are there. At places they have clear cytoplasm, and at places they can look little spindly as well. So you have to see it in a different sections. Like if in this area you may not be able to see the myoepithelial cells, but if you see here, the myoepithelial cells have become quite prominent. So if you see the overall lesions, if you see the overall papillae, you will be able to see that in some areas you can see prominently myoepithelial cells. Some areas you may not be able to see the myoepithelial cells, but you can at least judge that there are myoepithelial cells present in this lesion. So this lesion is benign lesion. When you are interpreting a SMA, it is very important to interpret that when you see SMA, when they mark the cells, you have to see that the cytoplasm has taken, and that there are blue nuclei which are actually not stained. That's how you should look for SMA positivity. Because what happens if you do SMA and there is a lot of myofibroblasts around, there is some inflammation which has happened in this lesion because of whatever reason, maybe infarction. So you can start to have more of a myofibroblastic proliferation, and SMA will be expressing those myofibroblasts around these layers, and then you start to have problem interpreting the SMA. So always pay attention when you are interpreting SMA in these myoepithelial cells. Now, benign papilloma can have different changes. It can have inflammation. It can undergo spontaneous necrosis, because the papillae can twist and then can become infarcted, and so infarcted necrosis can set. Once you have that, usually patient clinically present like a bloody nipple discharge. You can also see metaplasias in the intraductal papilloma, which can be of apocrine type, squamous type, sometimes or rarely you can have chondroid, osseous, or mucinous metaplasia. In any papillary lesions, once you start to see apocrine metaplasia like this, you should suspect that this is a benign intraductal papilloma. Some papillomas can show you very sclerotic fibrovascular spores, so you start to call them sclerotic papilloma. I had already mentioned that you have to be very cautious when you are interpreting CK56 or ER in areas which show apocrine change in a papilloma, because you will see that CK56 actually looks negative in the apocrine areas. So the apocrine cells doesn't take up CK56 even though they are benign cells. In a benign ductal papilloma, those will be benign cells, but still they show, it looks like they are negative. It's not like they have lost the expression, they are actually are negative. So don't interpret that as a loss of CK56 and do not call it a malignant lesion. So next question. I hope you have already scanned it. So I will just go to the quiz directly. Which of the following statements is false? Apocrine areas in papilloma show absence of CK56 expression. ER is diffusely expressed in papilloma. P63 expression is seen in periphery of the papillary DCIS and not in the papillae, and none of the above. So we still have 20 seconds to go. Okay. So the winner is ER is diffusely expressed in papilloma, and that's the correct. The majority of people, you people have answered it correctly. That ER is diffusely positive in papilloma is actually is a false statement, because papilloma is a benign lesion and ER usually is not diffusely expressed, but it will be heterogeneous. In some places you will see that ER expression is not there, whereas in some areas you will see there is some weak expression. In some areas you might see some moderate expression. So you will have a heterogeneous expression of ER in papilloma. I can say that the only lesion where it is not considered neoplastic and still show you papillary hyperplasia is actually apocrine metaplasia. In apocrine metaplasia, sometimes you see this small papillae, and which we call is actually apocrine papillary hyperplasia. And I know that this is a papillary proliferation because you can make out there is a fibrovascular core. So to call anything papillary, you have to have a fibrovascular core, which is quite obvious. That means it can be quite conspicuous or it can be inconspicuous. Without that fibrovascular core, you cannot call anything which is papillary. Now we are moving to the next lesion, which is papilloma with ADH or DCIS. So you have to have a benign papilloma in the background, and then you will have a focal area which is showing atypia, which can either be called atypical ductal hyperplasia or DCIS. What you have to remember that this whatever atypia, the lesion which is there has to be low to intermediate nuclear grade, and most often they show you solid and cubiform architecture. Myoepithelial cells will be reduced or absent in the area of the atypia, and there are so many articles which talk about how to define ADH involving papilloma versus DCIS. So Page et al. Did some study and they said that if the area of atypia is more than 3 millimeter, then we will call it DCIS. If anything less than 3 millimeter, you should call it ADH. Tavasoli et al., they came up with this idea that if the area of atypia is less than 30%, then you call it ADH. If it is anything between 30 to 90%, then you call it DCIS. Whereas Neat et al. They said that if the architecture is like DCIS, then whatever extent, regardless of extent, you just call it DCIS. What does WHO do? WHO actually uses this criteria of 3 millimeter size to say something which is ADIH in papilloma versus DCIS in papilloma. And what you have to understand, even though WHO has given this criteria, they also acknowledge that this is actually a very arbitrary criteria. Sometimes you will not be able to say with confidence whether it is ADH or DCIS. What I do in such cases that I don't try to tell them whether it is ADH or DCIS. I just say that there is atypia in this lesion, and this could be either ADH or this could be either DCIS. Now look at this lesion. This is a large duct which is dilated, and you see a proliferation within the duct. And I can say that this is a papillary proliferation because you see in the periphery here, there are some sclerosed papillae which can be seen, which are very pink looking here. On the both side, you can make out that there are these papillae, and within the center, you start to see something which is becoming more solid proliferation. If you go on to more higher power, you start to see that these papillae are there, which are sclerosed papillae. But in the center, you see this, there is some solid proliferation which is going on. And then I would like to go on much higher power and see what is happening there. If you see here, it is of proliferation which is of very monotonous appearing cells. And the nuclear weight definitely looks quite low. There is no heterogeneity in the cells. So I am suspecting whether this is definitely atypia. So I'm suspecting it could be ADH or DCIS in this lesion. So in such situations, you will have to use IHC to say whether this proliferation is actually clonal or polyclonal. So you use first marker you'll use is P63. What you are seeing in P63, that P63 is present within this papillae here at the periphery, and it looks reduced in the center where this more atypical looking proliferation is going on. Similarly in SMA also, SMA will be present in the papillae. It is present in the papillae, but it looks reduced in the center, a portion where there is atypical proliferation. And if you see ER is diffusely expressed in this area. So what is telling me that this is actually a some atypical proliferation, which is either ADH or DCIS in the papilloma. You go on to some another case here. You see another duct which is dilated, and you start to see very solid looking proliferation within these ducts. But what you even can make out in this low power, that you see here, that there is some papilla here, there is some sclerosis here. So this sclerosis tells me that there were papillary cores here which have become so sclerosed. So I am dealing with something which was actually was a papillary lesion, and within that there is something which is more solid proliferation which has occurred. And if you go on to high power, little high power, you start to see that in the periphery there is some residual papilla which can be seen, and these are this sclerosed papillae which are there, which tells me that this is actually a papillary lesion, and juxtaposed to this there is this solid proliferation. On high power, you start to see that this solid proliferation has got very monotonous looking cellular composition, and the nuclear weight is quite low. And when you use IHC, you see again P63 is reduced in this proliferation. SMA is also reduced in this proliferation. So the myofascial cells are definitely reduced or absent. CK5 is lost. So that is a very good clue that we are dealing with something which is clonal. And ER is diffusely and strongly positive. Another clue to tell you that we are dealing with something which is clonal. So this is actually a papilloma which is showing DCIS. Now we'll go to the quiz question number 3 or quiz 3. So I'm going to launch. The question is a 2 millimeter size high grade atypical epithelial proliferation in a papilloma should be labeled as papilloma with ADH, papilloma with DCIS, none of the above, or it can be I don't know, I am not very sure. I can see people are also typing in the box, and we still have 15 seconds to go. Okay, great. So most of the people have said that it will be papilloma with ADH. Some of them are saying papilloma with DCIS. So I can see it is still a hung house. So what you have to see in this question is what I have said is exactly high grade atypical epithelial proliferation. Now the criteria that cutoff criteria of 3 mm is there when you say something is ADH if it is less than 3 mm or something is DCIS when it is more than 3 mm. It actually applies only for low grade or intermediate grade atypical epithelial proliferation and not the high grade epithelial proliferation. Once you have anything which is high nuclear grade, you just have to call it a DCIS. You cannot call it ADH. So answer is papilloma with DCIS. So again, coming back to just what I explained, when you say something is ADH or DCIS by the criteria of 3 mm, then it has to be of low or intermediate nuclear grade. Any size, high nuclear grade proliferation within papilloma, you just have to label it as papilloma with DCIS. Now, this is another example of intraductal papillary lesion you can make out. This is actually a 14 gauge needle biopsy. It's a nice biopsy. You can make out a thick fibrous capsule of the this lesion or rather duct, and then you have this papillary proliferation here. You can make out it is papillary because one can make out even on the low power there is some sclerosed papilla here. Here some broad papillae you can make out, and if you look at here in the periphery on the left hand side, one start to see that there is some sawdil proliferation as opposed to this proliferation here, which looks more of a glandular proliferation or a papillary proliferation. You go on to high power and you start to see in what looks like a broad papillae. There actually you can make out epithelial and some myoepithelial cells. There is this sclerosed papilla also. If you go much higher power, one can make out that there is two cell population, luminal and abdominal myoepithelial cells in these ducts, and so this area definitely looks like it is a benign area or a benign papillary proliferation here, and there is some apocrine metaplasia also. That is also clue that I am dealing this area at least is a benign, but that area which looks solid is giving me a concern because I can see that there is a solid proliferation. Even at the low power, one can make out it rather looks quite monotonous. And if you look at the high power, definitely the cells are homogeneous, they are monotonous. So one start to suspect whether are we dealing with typical atypia in the papilloma, which it could be ADH or DCIS, and then I will use immunohistochemistry to say whether it is actually ADH or DCIS. You see the P63. P63 is again nicely preserved in the areas which look benign, but it is absent in the area which is that solid proliferation. On higher power, you can make out P63 is absent in this solid proliferation, whereas it is maintained or it is preserved in the myoepithelial cells, which are the areas which look benign. And now this is CK56. What do you see in CK56? This solid area is actually as preserved CK56 expression. If you go on to high power, you can make out this solid area is actually showing good heterogeneous positivity for CK56. It is also present in the areas which actually looked quite benign. And if you do the ER is also looks quite heterogeneous in this solid area. On high power also you can make out ER is quite heterogeneous. At places it is positive, at places it is negative. So what it has told me that this is actually is not a clonal proliferation, but it is a polyclonal proliferation within the otherwise which looks like a benign papilloma. So this is actually a papilloma which is showing you usual ductal hyperplasia, and it is not a papilloma which is showing ADH or DCIS. Now we'll come to the third category of the lesion in papillary lesions, which is papillary DCIS or also called ultraductal papillary carcinoma. What you have to remember that you should not see any pre-existing papilloma in this. That means you should not see any pre-existing benign papillary proliferation in it. So entire lesion should be neoplastic. Another thing you have to remember that the pure form of papillary DCIS is very rare. You usually see this papillary DCIS along with other type of DCIS in the adjacent ducts. You will have, as I already mentioned, you will have absence of myoepithelial cells within the fibrovascular course. There is a caution which you have to remember. sometimes within this course, papillary course of the DCIS, you can have a clear cell layer which can mimic like a myoepithelial cell layer, and those cells are actually called globoid cells. I will explain to you using two examples here. Now you see this papillary DCIS, you can see this slender papillae here, which at places sometimes you look like they're fusing and forming cubiform areas. But if you go on high power, you see nice slender papillae, and you can make out that it is lined by a single layer of columnar epithelium, which is atypical and which is of a low nuclear grade. There is even somoma bodies you can make out. And if you do P63, P63 is only present in the periphery of the lesion, but it is absent in the papillae. This is a papillary DCIS in which you can see there are some clear cells which are actually look like they are at the abdominal side. That means they are towards the stroma, and these clear cells actually can confuse you that whether these are actually myoepithelial cells. So these are the papillary cores which have even these clear cells, and then one may say that this looks like a benign lesion, or this is like a benign papilloma. You see other areas and you start to see those clear cells more prominently, and now you really start to suspect if these are actually myoepithelial cells. So in such situations, you will have to do IC to prove whether these are myoepithelial cells or not. And I did P63, and you can make out that P63 is negative. Those clear cells have not marked with P63. That means it looks like it is actually epithelial cells only, which are giving appearance of myoepithelial cells. This is another example. This is another example of globoid cells in a papillary DCIS, wherein you can see that there are a lot many these clear cells you can see within this papillae. On the higher power, you can start to see so many these clear cells, and which are actually towards the stromal side of this papilla, and definitely you will confuse it for myoepithelial cells. But if you do a P63 or CK5-6, you will note that those cells do not mark as a myoepithelial cells, and it is actually papillary DCIS, and some people call it a papillary DCIS, which is a dimorphic papillary DCIS. Since we are talking about papillary, I thought you should know about something which is also called micropapillary. And in micropapillary also, you tend to see the papillae. This is a micropapillary DCS. You have these ducts, which in the within the ducts you have this epithelial proliferation, and you actually seeing some papillae here. If you go on to high power, you start to see that there are these papillae. But what is the difference between the true papilla and this papilla is that you don't see a nice fibrovascular core within this papillae. This papillae towards the attachment of the duct is a thin and the luminal side will be the broad. So these what we call is actually micropapillae. These are actually pseudopapillae, and so we say that this is actually a micropapillary DCIS, because you can make out that this looks quite monotonous, and this has to be neoplastic. It is not a benign condition, but still, if you are doubt, you may resort to immunohistochemistry. And what you see on a P63 and SMA, that these all ducts have myoepithelial cells in the periphery, but there are no myoepithelial cells within this course or fibrovascular course. And if you do the ER is actually diffusely strongly positive in the entire lesion. That tells me that this is a clonal population, and then this is a micropapillary DCIS. Now we are moving to the fourth category of the lesion of the in the papillary lesions, that is the encapsulated papillary carcinoma. It is actually a variant of papillary carcinoma which is characterized by fine fibrovascular pores which are covered by neoplastic cells of low to intermediate nuclear grade, and it is usually surrounded by a thick fibrous capsule. So what we'll see is that there are no myoepithelial cells within the papillae as well as in the periphery of the lesion. These encapsulated papillary carcinomas in 13 to 32% of the cases can be associated with invasive carcinoma. And when you are to say something is invasive, you need to see invasion beyond the fibrous capsule of the lesion. That means it is into the adjacent adipose tissue or maybe the adjacent other structures. So if you have to calculate the T size, you only measure invasive component if there is any. Otherwise, you don't measure the only encapsulated papillary carcinoma for T size for staging purpose. So these tumors have low incidence of lymph node metastasis. Only 1 to 3% of the cases in the literature have shown that they can metastasize very rarely to lymph nodes. Local recurrence rate is very rare, and very rare cases have been shown to um, invade into the skeletal vessel, but that is usually happens when something is done earlier, like if there is a history of previous surgery. They usually have favorable prognosis once you adequately excise them, and as per as WHO staging is concerned, these are considered as tumor in situ unless there is a frank invasive components present in the tumor. So now look at this one example. You have very thick fibrous capsule of a lesion which is quite nodular or encapsulated, and within that you start to see this papillary lesion. Even on the low power, what is different from the papilloma which was seen earlier, that these lesions to me at least looks quite blue. You start to see this very blue looking proliferation, papillary proliferation. The papillae are quite slender here. They're not very broad like what you saw it in papillomas. And if you go on to high power, you actually see that these papillae are quite slender, and they are lined by this monotonous appearing atypical ductal cells, which are of low to intermediate nuclear grade. Even in this picture, you can see the same thing. These are of low to intermediate nuclear grade slender papillae. And if you do the immunohistochemistry, what you see in a P63, that the myoepithelial cells are absent within the papillae as well as in the periphery of the lesion as well. Same thing you can see, CK56 shows that it is lost in this proliferation, and even you cannot make out any myoepithelial cells. There are very few myoepithelial cells you can see here, but that could be because of some residual duct there. SMA again shows that you have absent myoepithelial cell within the papillae as well as in the periphery of the lesion. This is what I was talking about SMA, that it has got a cross-reactive with myofibroblast. And in this left upper corner image, you can see that SMA has cross-reacted with myofibroblast, and sometimes it can really pose a challenge to see if there are absent myoepithelial cells or present. Now, this is another example of a nice encapsulated papillary carcinoma. You can see that this is nicely encapsulated lesion, which has got a thick fibrous capsule, and within that you start to see that there is a papillary proliferation. Adjacent to it, there is some proliferation here. If you go on to, this is another section where again you see thick fibrous capsule within which there is a papillary proliferation, and there are adjacent ducts also which are showing some proliferation on higher power. Yes, this papillary proliferation within thick fibrous capsule, and adjacent area is also showing you something which is like proliferation, which is an intraductal proliferation, and which looks cribriform at least at this power. You see, this is a proliferation of a encapsulated papillary carcinoma, and just adjacent to it there is this intraductal proliferation, or rather it looks intraductal proliferation, which has got cribriform architecture. Within the papillary carcinoma, these are slender papillae which are lined by these atypical ductal cells which are of low to intermediate nuclear grade. And if you do CK56, what you are seeing is the CK56 lost within the lesion as well as in the periphery of this encapsulated papillary carcinoma. But in the adjacent, that intraductal proliferation also, you can make out that CK56 expression is lost. Very few ducts are here are showing the expression in the periphery, which are the myoepithelial cells. So very few ducts are showing there are myoepithelial cells, but most of this proliferation is showing absent myoepithelial cells. And on the higher power, same thing can be seen, that the myoepithelial cells are absent within the encapsulated papillary carcinoma, and this adjacent intraductal or interductal like proliferation. Same thing you can make out on P63. On P63 also absence of myoepithelial cells within the encapsulated papillary carcinoma and this adjacent interductal papillary proliferation. So what it is actually encapsulated papillary carcinoma, which is associated with invasive cribriform carcinoma. So in such cases, what you will have to do is that you will have to measure T size by the size of this invasive cribriform carcinoma. That will be used for a staging purpose. Now we're coming to the solid papillary carcinoma. So in previous edition of 2003 WHO classification, it was actually clubbed with encapsulated papillary carcinoma, and it is separated in the latest 2019 classification, as well as the previous one, 2012 classification. What you see in this is that you have expensive cellular nodule or nodules which have a solid proliferation and have inconspicuous or delicate fibrovascular cores. Nuclei are always low to intermediate nuclear grade, and you can have neuroendocrine differentiation in this proliferation. You sometimes can see spindle cell morphology, and also sometimes you can see mucin production within the cells. Now you will have myoepithelial cells absent within the lesion, within this proliferation, and also it will be absent around the nodules, but sometimes you can have discontinuous myoepithelial cells. So this is one example wherein it actually looked like a one single nodule on the gross. I don't have the complete scanner image, but whatever the lowest image I could photograph, you can see that it looks like quite circumscribed nodule and looked quite solid. If you go on to high power, now you want to start to say that within this large nodule, there are multiple nodules here. If you go on to more high power, you start to see that it is a proliferation which is solid and of very monotonous looking low nuclear grade proliferation. And in between, then you start to see some thin fibrovascular septi, which are very inconspicuous on lower power. So on higher power, you start to see this inconspicuous fibrovascular cores around which you have this very monotonous low to intermediate nuclear grade proliferation of cells. So you start to suspect that this is probably is a solid papillary carcinoma. If you want to do IC, if you do sesame, you will see that there are no myoepithelial within this proliferation or around even the nodules. And this proliferation is also showing you neuroendocrine differentiation. Cyanotophysin is nicely and diffusely positive. Chromogranin is focally positive. So it was actually solid papillary carcinoma, which showed you some neuroendocrine differentiation. So it is actually regarded as an in situ or a DCIS a tumor when you have rounded nodular masses without any infiltrative pattern and without any stromal reaction. But there are rare variants wherein you have very irregularly shaped islands which are arranged in a jigsaw pattern, and there you see them in a desmoplastic stroma. And obviously there is no myoepithelial cell layer in this, so you can call them such lesions as invasive solid papillary carcinomas. So what WHO 2019 says that in the absence of any obvious conventional invasive component or the features of invasive solid papillary carcinoma should be staged as PT in situ or DCIS, regardless whether a myoepithelial cell layer is identified or not. So that's the statement from WHO 2019. This is another example of solid papillary carcinoma. You can make out on the scanner image that there are different size nodules are there, which are forming a definite mass, which is must be around 2 centimeter size, and you don't see that these are infiltrating into the adjacent fat. The stroma looks quite not so reactive, at least on this power. If you move on to little higher power, you start to see that these are of different size nodules. Another, and then more high power, you start to see that within the nodules there is this monotonous solid proliferation, and then there are these inconspicuous thin fibrovascular cores which are there. Nuclear grade is definitely low, so this is definitely a solid papillary carcinoma. And but there was an area within this lesion wherein you start to see that something which is infiltrating has a very small nest, and which is going into the fat also. So this area looks like it probably we are dealing with something which is invasive carcinoma along with solid papillary carcinoma, and that is on the high power. You can make out, yes, we may be dealing with invasive carcinoma here. If you do CK56 absent in this area which look like invasive tumor. It is absent in some areas of the nodules, but it can be discontinuously seen in some of the nodules, which can happen in solid papillary carcinoma. Same thing which can be seen in high power. Again, P63 shows that it is absent in this infiltrative tumor, and somewhere it is discontinuously present in the nodules of the solid papillary carcinoma, but it is definitely absent in the invasive tumor. and ER is differently positive everywhere in the tumor. So this is actually a solid papillary carcinoma associated with invasive breast carcinoma, which is not of any special type. So we had a case wherein there was a solid papillary carcinoma as well as encapsulated papillary carcinomas together. So you can have solid papillary carcinomas with either invasive breast carcinomas or invasive mucinous carcinomas or invasive solid papillary carcinomas also. Similarly, encapsulated papillary carcinomas can also have you invasive breast carcinomas of a different types. So this is, I think, is a probably is the last question. So I will launch the quiz. The question is, which of the following is not a feature of solid papillary carcinoma? First option is intracellular mucin, second is neuroendocrine differentiation, third is spindle cell morphology, and fourth is high grade nuclei. So we still have 15 more seconds to go. So let us see the result. Great. So most of the people have chosen high grade nuclei is not a feature of solid papillary carcinoma, and that is actually is the correct answer. So solid papillary carcinomas can show you, as I already mentioned, intracellular mucin. I have shown you a case wherein there was a neuroendocrine differentiation. Sometimes you can show you spindle cell morphology, but it always shows you low to intermediate grade nuclei. If you start to see something which looks like a solid papillary carcinoma and it has got a high grade nuclei, you cannot call it a solid papillary carcinoma, or you cannot stage it as like a in situ carcinoma. You will have to put it like this is a high grade carcinoma which has a solid papillary like morphology, and the entire tumor will be calculated for a PT stage. When you are dealing with papillary lesions, something you have to be aware of, that there is something called as epithelial displacement which occurs when you do a biopsy or of FNAC in these lesions. So what happens is that the nest of epithelial cells which come out through that needle tract and get dislodged and get launched into the lodged into the needle tract area. So you see that like this small ductal clusters which gets lodged into this the tract of the needle, and that can pose a challenge that when you are trying to interpret whether this is invasive tumor or not an invasive tumor. But what you have to see, that the needle tract can be identified by few things, like you will see that there is a fibrosis, there is a fat necrosis, there will be some collection of hemocytin macrophages, there will be some inflammation also going on around, and within that if you see something which are like atypical looking nuclei but they are even degenerating, then this is most likely epithelial displacement rather than a it is an invasive tumor there. In such a scenario, myoepithelial stains are not useful. So do not attempt to do the myoepithelial cells stain, because those will be negative and you might falsely interpret it as something which is an invasive tumor. Now coming to invasive papillary carcinoma, it is extremely rare category of special type of breast carcinomas, and you say something is invasive papillary carcinoma when more than 90% of the tumor should show you papillary morphology, and those papillae should be have a permeating growth. It should be infiltrating very widely into the adjacent breast parenchyma. And when you are dealing with something which looks like invasive papillary carcinoma, what you have to remember is that you always have to rule out metastasis from other organ. The most common like ovary or lung, those can also metastasize to breast. Once you rule out that this invasive papillary carcinoma is not a metastasis, then only you can call it a invasive papillary carcinoma of the breast. Now this is an example of invasive papillary carcinoma. You can make out that this very irregular um, uh, uh, pattern of the infiltration is seen within the stroma. Stroma is so fibrous, so there is a stromal reaction also. And on higher power, you start to see that there are broad papillae as well as some very slender looking papillae, and the nuclear grade is very high. So this is a tumor which has got high nuclear grade. It is widely infiltrating into the stroma. So it is an invasive papillary carcinoma of the breast. And if you really want to show that there are absent myoepithelial cells, then you can use SMAP 63656, and those should be absent in this tumor. This tumor was the example of this tumor was a triple negative tumor. That means it was ER, PR, and HER2 negative. So all three markers were negative. So we call it a triple negative tumor. Since we are talking about invasive papillary carcinoma, I thought one should talk about invasive micropapillary carcinoma also. So invasive micropapillary carcinoma has got very peculiar morphology. What you see this very thin, slender papillary cores which are there, which are actually present within this artifactually empty spaces. So there is a retraction of stroma around this thin fibrous septae, and you see that it actually looks like they are floating within the some empty spaces. And another feature of this, that the luminal side of the cells is actually towards the stroma and not inside. So what we call it inside out pattern, what we even call is as a reverse polarity. Now if you have a doubt that whether it is reverse polarity or is there or not, whether it is actually papillary carcinoma or not, one can resort to do stain which is commonly available, which is EMA. When you see EMA will show that it is actually marking the apical side of the cells which is towards the stroma, like this. All these clusters have strong apical staining, which otherwise in a normal breast, if you see in this, is actually towards the luminal side. Even in a breast carcinoma which forms tubules, the image expression is actually towards the luminal side. That means with inside. But in the invasive papillary carcinoma, you are seeing that expression which is outside. So that is what I meant by inside out expression of EMA or inside out pattern, which is called reverse polarity. And this is what you see it in invasive micropapillary carcinoma. There is one peculiarity about it, that sometimes in this tumor you have this HER2 expression, which is actually a moderate expression and which is not a complete. It is actually in the basolateral areas. So the apical area, or the one side of the cell, is actually not marked. Even though it is incomplete membrane staining, WHO says that you have to report it as a equivocal, so that this tumors will have benefit of reflex fish amplification, and some of the tumors can actually amplify and they can have anti-HER2 therapy. This particular tumor was ER diffusely positive, it was PR negative, and there is one peculiar tumor which is there, which looks, it is, I will tell the name. You can see that this lesion was there in elderly female. It was around 2 to 2.5 centimeter in size. You can see that this is nice nodular lesion, mass forming lesion, and it's not actually infiltrated. The border are circumscribed, but doesn't look that much infiltrated. If you go on to little higher power, you start to see that within this large nodular lesion, there are multiple nodules actually. And you go on to another power, you start to see there are nodules here. You are, you start to see some microcalcifications here. Another high power, you start to see microcalcification. And within these nodules, you see there is this proliferation, which looks rather columnar-like. You see columnar-like proliferation, and within the nodules are also there are this fibrovascular septae are also there within these nodules. You can make out this fibroscope. What is unique about this columnar proliferation, that this actually cells, or the nuclei in the cells, which should be basally located, that means toward these fibrovascular cores, but they are actually towards the luminal surface. So this is actually showing a reverse polarity. So the nuclei are not basally located, but they are towards the luminal side. This is also called as reverse polarity in this particular variant of a unique tumor. So it is composed of nodules. Has got this thin fibrovascular septae, and then columnar morphology. The nuclear grade is low to intermediate nuclear grade, and then you have this reverse polarity. If you see carefully, some of the nuclei actually show you nuclear grooves also, and some places you might see some actually clearing in the nuclei also. This actually resembles something like a tall cell carcinoma of the of the thyroid, but it is in the breast. It is called tall cell carcinoma with reverse polarity. Once upon time, these were also called solid papillary carcinoma with reverse polarity. But the latest WT says that you don't use the word solid papillary carcinoma for this kind of tumors. This is actually a rare variant of invasive tumor, which is called tall cell carcinoma with reverse polarity. If you do the IHC in this, you see that P63 is absent within the nodules as well as in the periphery of the nodules. And actually this tumor express basal cytokeratins. In this case, it is CK56 nicely and diffusely positive. So this tall cell carcinoma with reverse polarity was actually recently described in 2003. It is actually subtype of papillary carcinoma. I have already mentioned that this is a solid nodules of columnar cells, and architecture I have mentioned. What is important to note that they frequently show you this IDS2 R172 hotspot mutations, and most often these are actually triple negative phenotype, but they are actually low malignant potential. So tumor is low grade, but they are triple negative. So that's are the characteristics of this unique tumor. So in summary of the papillary lesions, papillary lesions of the breast may be benign, they can be atypical or in situ or invasive. And to distinguish them accurately, you have to pay attention to the histology very carefully. And in some circumstances, you will have to use immunohistochemistry to show the presence or absence of myoepithelial cells, or to show if this ductal proliferation is actually clonal or polyclonal. To summarize with this diagram, one can see that in benign intraductal papilloma, you have these dots, which are actually myoepithelial cells, which are present within the papillae as well as in the periphery of the lesion. In the papilloma, which shows ADH or DCIS, you have myoepithelial cells which are reduced within the area of atypia, but it will be present elsewhere where there is benign looking papillae, as well as myoepithelial cells will be present in the periphery of the lesion. In papillary DCIS, myoepithelial cells are absent within the papillae, but they are present in the periphery. In encapsulated papillary carcinoma, you have absence of myoepithelial cells within the papillae as well as in the periphery. And in solitary papillary carcinoma, you have absent myoepithelial cells within the nodules as well as in the periphery of the nodules, but rarely you can have discontinuous myoepithelial cells in the solid papillary carcinoma. So with that, I will stop. Thank you very much.